All right, so I think last time we briefly talked about non-invasive ventilation in the frame of reference of not only negative pressure ventilation, but some of the other alternatives to non-invasive. But specifically, we're talking about ventilating somebody without the placement of an artificial airway. Negative pressure, again, with cuirass or with iron lung is a possibility, but more often than not, we're talking about positive pressure. And we can do this non-invasive, although it's not really ventilation. We can just apply a single pressure CPAP or an alteration between the two different levels, what has come to be known as BiPAP. Now, BiPAP is a trademark term through Respironics. So other manufacturers will just simply call it non-invasive ventilation in the process. The two terms we're going to be utilizing, the two settings we're going to be utilizing, I should say, is IPAP, which would be the inspiratory positive airway pressure. That's the pressure that's applied during the inspiratory phase. Then it alternates with, obviously, that which occurs during the expiratory phase, or EPAP. So IPAP and EPAP. The difference between the two of them is called delta, and that is the pressure that is basically used to increase the tidal volume on a spontaneously breathing patient. We're going to also call this, when it's during mechanical ventilation on a spontaneous breath, something called pressure support ventilation, or PSV. But we'll get to that. The idea behind both of them is to take whatever tidal volume the patient has and make it larger. Increase delta, increase tidal volume. Okay? EPAP, on the other hand, is your baseline pressure, and that's related to the PEEP or CPAP level that we would see on a mechanically ventilated patient. So if the problem is oxygenation, increasing the EPAP will increase the oxygenation. If the problem is CO2 removal, increasing the delta pressure will make that CO2 level lower. Got it? Let me say it again, because it's kind of an important concept. EPAP is going to dictate the oxygenation levels. It's going to increase the FRC the same as PEEP or CPAP would do. Increasing the delta pressure, the difference between the two of them, will increase the amount of alveolar ventilation you have because the tidal volume is now larger. Therefore, my arterial CO2 will fall as I increase the delta. Now, they're two separate controls, independent of each other. So when you change one, you potentially change the delta. You need to be careful. If, for instance, if I increase the EPAP level but do nothing to the IPAP level, I make the delta smaller. And that may not be a desirable effect. So you always need to pay attention to where those two settings are. Okay? Because that obviously is going to change the level of pressure support that you have, or support that you have, and therefore the tidal volume. Questions? Yes.
So,
Thank God. Because I hate hearing myself talk.
so the IPAP, you said is gonna dictate the CO2?
No.
What
The
is,
delta.
okay,
The difference between the two of them dictates the size of the tidal volume and therefore the amount of CO2 that's removed.
so the EPAP directly dictates the oxygenation level?
Correct. Correct. That's your baseline pressure, just starting from.
Okay.
Unlike the situation where I'm putting a pressure above, so for instance, when I'm in pressure ventilation, I'm setting a baseline and I'm setting a pressure above that baseline. This is different. These are two independent values. The difference between them dictates the CO2. Dana.
Okay, so the EPAP controls like the oxygen levels by increasing the FRC,
Correct?
and then the delta increases tidal volume,
That is correct.
which then would increase the alveolar minute ventilation, decreasing the PaCO2.
Didn't I just say that?
I'm just making sure I understood
Wow.
it correctly.
You understood it correctly.
What is IPAP then? Does that do anything, or?
It only does it in the sense that it affects delta.
Okay.
So if I had an oxygenation problem, I would increase the EPAP. But I need to keep delta the same, so I would increase the IPAP by exactly the same amount.
So they move together.
They move together. I may have a slide on this, but I'll show you now. Let's say I had a situation where I had an IPAP level of 10 and an EPAP level of 5. I get a blood gas back and my PaO2 is 50. Okay, and let's say that's on 60%, so the option really isn't to go up on EFiO2. I would increase the EPAP to 7, but I would need to keep the delta the same by increasing the IPAP. Because let's say in that instance my PaCO2 was 40. I don't want to change that. That's where I want it. Is that clear? Let's say I had a situation where they were both 50 and the pH was low and I wanted to improve it. In that case, instead of going, I would go up on the EPAP to fix the PaO2 problem, but I could also go up on the IPAP and change the delta to a bigger delta. So here my delta was 5, here my delta is now 7. That'll correct that PaCO2 problem that exists there also.
Why aren't we just calling this PEEP and PIP?
Because they're different. PIP, by definition, is a pressure that's placed above the baseline level. These are two independent numbers. It's semantics to some extent, but that's just kind of the way the units are designed. And it gets confusing when you start talking to physicians and they don't understand entirely what's going on. So you need to have a very good foundation of it. Yes, Alyssa.
So what exactly is the significance of the delta pressure?
Changing CO2.
That's just like,
That's it.
okay.
Okay. Let me continue on so I can confuse you further. If the IPAP and the EPAP are exactly the same number, well, that's CPAP. That's basically what we would use for obstructive sleep apnea or something along that line. Okay? So you can set it up so that they're not getting any boost at all. All they're getting is a baseline pressure that's elevated, if that is what it's designed for. We would use the sleep study again to be able to determine the respiratory disturbance index, and if you remember, that's basically the sum of the apneas that exist and the hypopneas that exist, apnea being a cessation of airflow for 10 seconds, hypopnea being reduced airflow that causes some desaturation in the process. Okay. That should be review. And then it's just showing you the positive pressure that's there, blah, 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 blah. So why do we put somebody on non-invasive ventilation? Well, somebody needs to be ventilated. Their PaCO2 has risen, their pH has fallen, and I want to be able to correct that abnormality. We can use this especially with patients with chronic muscle fatigue. So somebody who has, is there something wrong?
Yeah, it says the indications for BiCAP instead of indications for.
Oh.
Is that like the same?
Yeah. Let's just use the term non-invasive ventilation.
Okay.
That way we're not causing problems with anybody's trademark and patent. Because, I don't want to be sued. So somebody who has chronic ventilatory failure, sometimes they just need a little bit of a recharge overnight. So like a lot of the kids at camp, all they needed to do was just have a small amount of boost while they're sleeping to prevent those hypoxemic episodes, and they'll be fine. Sometimes somebody who we wean them or we extubate them from invasive ventilation, but we jump the gun a little bit. We extubated a little bit too early, and they still need some support. Well, a simple enough method is just to use non-invasive ventilation. Patients who don't wish to be intubated, but they still want some support. Okay. The most common is the last group there. Probably should throw COPD patients there also. So patients who are in pulmonary edema all they need is some support, some improvement in oxygenation, some little help with ventilation until the diuretics can kick in and reduce their preload. Okay. COPD patients, same thing. They just need a little bit of help to overcome the exacerbations secondary to a pneumonia. Get some antibiotics on board, support them, and then go ahead and withdraw it. Patients who you don't want to do it on, patients who need invasive mechanical ventilation. Somebody in the ARDS, somebody who has profound respiratory failure, this is not the option. Really, they need to be intubated and ventilated at that point. Okay. Somebody who is apneic, a drug overdose. This is not support in the sense of a full support of ventilation. This is something that's helping their spontaneous efforts. If they don't have spontaneous efforts, this ain't going to help you. Okay. Someone who has aspiration or a possibility of aspiration of a poor cough and gag reflex, got to use caution with it. Obviously, anybody who has an untreated pneumothorax. Patients that are profoundly hypotensive, again, they probably need invasive ventilation. Somebody who has some allergies to the mask material, although there's so many different types of interfaces that should not be something we can't overcome. And then obviously some other issues that are there. One of the things we'll do this afternoon is you'll put each other on some non-invasive ventilation, and you'll get a feel for why patients don't like it, because it is a very uncomfortable feeling. Bunch of different units that are out there. Some places have that model, although it's very, very old. This one, we finally stopped teaching it a couple years ago because it's confusing. But the two that we're going to focus on are the Vision and the V60. The V60 just basically being the new model that is there. This was the old BiPAP STD. It sounds terrible, but it's spontaneous timed. And it was really a bunch of different units that were integrated, and it was a mess. This is the Vision, which is the more common one. It's touch screen, a little bit nicer interface. But they all have the same kind of setup that they end up having, and we'll go through the circuitry in a second. This is the V60, even more modern as far as the touch screen that we'll end up seeing. Your PE that you'll do, Nancy and I will choose one of the two, so you got to know both, because you may walk into a hospital and whichever one they have available is the one that you'll end up setting a patient up on. All right, let's talk about some of the things that we're dealing with, really with both of them. And all non-invasive ventilators all function kind of the same way in that they're blowers. They're reverse vacuums. Okay, so all they're doing is continually outputting a flow of gas. And we're talking about that flow of gas then generating a pressure within the circuitry. Okay, faster the flow, higher the pressure. Okay, and in some cases they can go, up to 300 liters per minute. Okay, one of the key parts is that when there's leaks in the system, in an actuality where we will want a leak in the system, simply because if the mask is fitting on the patient's face and there's not a leak, it's too tight and you'll get pressure sores. So we want a small amount of leak to be present, and these units can compensate for those leaks. And you need to have a sensitive system because it wants to sense when the patient is triggering the breath on, in other words, transitioning from EPAP to IPAP. And we want to know when they're no longer taking a breath in, when they're basically their inspiratory phase has ended, so it can transition back to to the EPAP level. So with non-invasive, we're alternating between those two levels, and it's alternating on those two levels by changing the speed of the gas going through the circuitry. Back and forth it goes. Okay. And they have integrated oxygen molecules so you can dial in a specific FiO2. Prior versions did not have that option. Now this is not a blender. It's different than the blender that you guys set up for using, say, an oxyhood or the other devices that were there that Mary covered last semester. Okay. At lower FiO2s, it's got some pretty good accuracy, but as you get higher and higher, because that blower has to change speed, gets a little bit less accurate as you get to higher and higher FiO2s. And again, if somebody needs their high FiO2, they probably need to be intubated and put on a ventilator, not simply on a non-invasive. And what this is showing is that as you get to higher and higher concentrations, it becomes a little bit less stable as far as its ability to keep up with it. Don't you love schematics? Kind of wonderful, aren't they? But basically, it's drawing in ambient air, running it through a blower, and then going ahead and monitoring how much flow is present before it comes out on its way to the patient. So there's all kind of internal mechanics that are there to be able to regulate that flow and know when to transition from inspiratory to expiratory. Do I expect you to know that no. But know that it's a blower. Know that it's something where the speed of the gas is being changed to alter the pressure within the circuitry. So basically that's what we're ending up doing. We're drawing in air, running it through a blower, running it then through a flow sensor to be able to monitor what flow is present, and then pressurizing it. Now, one of the differences that is present here is there is a proximal pressure line in addition to the main flow tubing that the patient had. When you looked at the ventilators previously, first of all, we had a dual limb circuitry. We had an inspiratory limb and an expiratory limb. Here it's just one limb. There's no gas coming back to the unit. It's just being gas delivering it to the patient. It's a single limb circuit. In addition, there's a pressure line, pressure hose, that is a small bore tubing that runs parallel to the gas delivery tubing that's monitoring the pressure at the proximal point. So at the point of their mask or at the point of their whatever interface you're using, the pressure is being monitored at that point. Because then what has to know is the pressure that I'm delivering the appropriate pressure that you want to have set. So if I want 10 over 5, am I delivering 10 over 5? But I'm monitoring at the patient as opposed to monitoring internal to the machine. So drawing in air, running it through my blower, monitoring the flow, and monitoring the pressure. V60 is kind of a similar setup. Again, just drawing in this case, it's drawing in ambient air. And both of them are hooked up to an oxygen source so that you can get a specific FiO2, and it's being monitored downstream. So here is my interface where I have, in this case, a nasal mask just going over their nose, held in place by a head strap. And this afternoon we'll talk about interfaces and let you play. But basically, there's two different types of leak that are present, because the flow that is going to the patient and the flow that is leaking is what is the total flow. So the total output includes what goes to the patient and what is leaking. There has to be a leak in the system because otherwise they wouldn't be able to exhale. Right? There's no place for the expiratory gas to go when they're exhaling. That's why there's a leak. So there's an intentional leak that is present there to flush the gas out of the mask that they're exhaling, flush the CO2 out. It's also a small unintentional leak. In other words, a leak that we create because the mask isn't totally fit. And it takes into account both of those, and I'll show you how in a sec. Intentional and unintentional. Again, if there's a big leak that the ventilator doesn't know about, problems will occur as far as it being able to sense a breath being desired and transitioning from EPAP to IPAP, and when the patient's begun to exhale. And these units use something called auto-track sensitivity to track those leaks and adjust for them. The way that it knows this is we're going to do a test before we start. On the Vision, it's called the exhalation port test. On the V60, we're going to tell it what kind of interface is present, and it knows what the leak should end up being. So we'll do a self-test in verifying that exhalation port leak is present. A lot of times clinicians forget to do this because they're in a hurry or whatever, but in that case you'll end up seeing, instead of patient leak, you'll see just this terminology, total leak, when it's displayed. It takes 2 minutes to do. I don't know why they don't bother doing it. It's simple. When you turn the unit on, there's a little place, there's a series of soft keys, and this is saying test exhalation port. We install the circuit, we occlude the outlet, we press start test, which is here, and it runs through and generates a flow. And once it's done, it'll say pass, and then you go ahead and just press the monitoring key to exit. Okay. Yeah. Yep. Oh, yeah. Please leave it in English. Just saying. Once you get a test complete, that means that you have determined what the leak is within the circuitry, the intended leak, and you can go ahead then and just press the monitoring hard key to exit. A couple other errors that you can end up getting, basically making sure that there's the system was, the cork is in it, and you're able to repeat it. Make sure the proximal line's hooked up. There's just some of the errors that are there. Biggest thing is not being tightly fit. On the V60, we're going to do what's called a mask test. When you turn it on, there's a spot there. Yeah, Steve.
So when you're doing this, you're just including the outlet, or you're
Yes.
putting a mask on the patient?
You're including the outlet
So where is it testing for leaks at?
within its circuitry. What it's doing is it's basically knowing. It's hard to explain without showing you. Within the circuit itself, there's a built-in leak. We just want to quantify what that built-in leak is. So if I occlude the end of it, it's going to put a flow of gas through, knowing how much is being leaked out. And it's just basically quantifying that.
Where's it leaking out?
There's a port on the, it's called a whisper swivel, that there's a built-in leak there for it.
Because then when you put the mask on, then the value that comes up on the screen will give you that value. Plus, it knows what the visitor is.
It'll make more sense when you see it. You got to trust me on that one. All right. There also then is, if we go to on the V60, the other model, there's a mask port that you're when you select that, it'll go ahead and allow you to select anything from a closed system like an endotracheal tube, all the way through other types of Respironics masks. On the packaging itself, it'll tell you what the leak number is. So it goes from 1 to 4, and on the package it'll say this mask is a 2, or this mask is a 3. If you're not using a Respironics mask, notice how they kind of built this into the system, that if you use their equipment it's a whole lot easier. You press other, it'll go through and do a measurement on it. And there you can see the different leaks that are present. So masks not manufactured by Respironics, you would select other.
So they're interchangeable, you can use different masks with
There are probably, I don't know, 40, 50 different interfaces you can end up using. They're huge. And the same is true with once you get the mask selected as far as what kind of interface you have. You then also need to tell it what type of exhalation port you're ending up using. And this is that disposable one that you end up having, or a whisper swivel, which is another example. And again, you got to see these things to really understand what's going on. But these are designed to have a small amount of leak in them. But the whisper swivel or the disposable exhalation port are the two most common that we'll end up using. And then what to do if it fails. Go from there. Power switch is of course not on the Vision, is located on the back. Which is always a wonderful place for it. There is also a filter on the back that you'll need to. This is an air intake filter, so you just want to make sure that there's not any dust built up on it. And then there's a 50 psi oxygen hose that goes there. On the front panel, a couple of important things. First of all, on the lower right corner, there is a patient interface port where the big tubing goes, and there's a pressure line port that is there. It's a proximal pressure port where a small tubing goes. And when you look at the circuit, you'll see one big tubing like a big aerosol hose, and the other one being a proximal pressure line. There also are a series of soft touch keys that relate to whatever's in the box next to them. There's also some hard keys which are basically used to change what's being displayed on the monitor. And there's a big adjustment knob that is there. So there's my proximal line port and my patient interface port, which is basically the 22 millimeter size tubing along with a filter. The adjustment knob is used to make changes. So when I touch a soft key, let's say I want to set the IPAP level, I go here and I touch the soft key for IPAP. I adjust the adjustment knob to the desired level, and I go ahead and I press the soft key again to lock it into place. It's not rocket science. Okay. And they actually have little clicking sensations to them to tell you when you're going up a notch. There's my soft keys. Depending upon the mode, the soft key value will change. They're set, or they're it'll tell you what the parameter that you're using, what the current set value is, what the measured value is, and what the units are in. So for instance, my EPAP is at 6 centimeters of water. My IPAP's at 15, my rate's at 12. And then there's the hard keys that are located on the lower left. Monitoring is kind of the default one. The screen that we're going to be in most of the time is going to be in the monitoring screen. If I want to go ahead and make a change to my parameters, I go ahead and select the parameters one. There's a mode one, and there's an alarm one. Again, the monitoring is kind of the home screen, and it shows you here, tells you which one I'm in, monitoring. And I end up having then a display of the graphs, pressure, volume, and flow, as well as what the current settings are that are there. If we don't do anything, it'll default back to the screen after about 3 minutes. on my values. Parameters then goes ahead and allows me to make a change if I want to. And as I change the mode, it'll only display what that mode contains. So in CPAP, it won't show you an IPAP or EPAP level. It'll just show you one level of CPAP. And again, to change the IPAP level, I just touch the soft key, adjust the knob, and hit it again to lock it into place. Two modes that are present, CPAP and spontaneous timed. The spontaneous timed is the one, obviously, that we're going to be utilizing to create an alternation between IPAP and EPAP. And when I go to changing the mode, it'll go, right now it's in CPAP. If I were to touch that, turn the knob, I would go ahead and alter the mode. So here I press mode, select a new mode, select my parameters associated with that, and activate new mode, which is in the lower right, to change everything over. And the alarms are basically there to go ahead and allow us to set alarms associated with them, and we'll talk about them in a second. Finally, there's graph control keys, which allow us to go ahead and adjust the scale of the graphics, as well as to freeze them, send them to an optional printer, which I've never seen, but I guess it's a possibility. I'm sorry, I said freeze on freeze. It's not a printer. This is the important spot to notice where I have my alarm silence. On most mechanical ventilators, there's two things you're concerned with. Where's the on-off switch? How do I shut the thing up? So that's how you shut it up. There is also a ventilator inoperative indicator there, and that's kind of the one you never want to see, telling me there's something wrong with the software internally, and that tells you that it needs to be repaired. So my alarm silence. And the alarm reset allows us to go ahead and reset the alarms. When an alarm condition occurs, it'll display it. If it corrects itself, it'll stay displayed so you know that that alarm occurred since the last time you looked at it. Hitting an alarm reset cancels everything out and resets everything for the next event to occur. So 2-minute alarm silence, and then the alarm reset is right below it. And this is that check ventilator indicator spot. Has a little wrench that'll pop up telling me that it's inoperative. And it's got a little, I don't know, eyeball, what else to call it. That basically is a abnormal condition has existed and should be referred for service. And when you look at them, you'll see that there are two indicators there that aren't lit. If they're lit, then pull the ventilator. And in my graphics, there's a little messaging area up on top. The graphic display area is in the center, and there's some data on the bottom that is there that it continually will display. Okay. Now, the monitoring section up on top will display some other values that are there as far as the estimated tidal volume and estimated minute volume. Again, it doesn't measure the exhaled volume like our invasive ventilators do, but based upon what it's guesstimating the pressure is generating, it can guesstimate, or I guess that's the best way to put it, estimate what the tidal volume and therefore the minute ventilation is. It'll also show the leak that is present as far as the patient leak. If that exhalation test was performed, it'll show you what the percentage of the inspiratory time is to the total cycle time and the percentage of patient-triggered breaths. Big thing to remember with non-invasive ventilation is this is not designed to take over ventilation entirely. If the patient needs to be ventilated, they don't need to be on this ventilator. This is designed to support spontaneous ventilation. Okay. So there's a performance verification just like on the other ventilators. And it's 13 different steps. I don't expect you to memorize them. You put in some settings, you verify the various alarm functions. You can walk through it yourself. In the CPAP mode, there's only two settings that you set, a pressure and an FiO2. And that's really it. Goes from about 4 to 20 centimeters of water. Why you would want to have somebody on 20 of CPAP is kind of cruel, but it does go that high. You want to remember that when you get below 4 centimeters of water, you probably don't have enough flow going through there to flush out CO2. So minimum value is always going to be 4 at the very least. And then we have some alarms that are there as far as a high pressure, a low pressure. The low pressure can be delayed, so we don't want to have each and every instance of it occurring. There'll be a delay that is there. An apnea value and a low minute volume. In addition, there's a high and low rate. And two other soft keys that are there, learn base flow, where if I'm all of a sudden putting a treatment in line, I'm now adding flow to the circuitry that wasn't there before. So I need to tell it to recalculate the flow based upon that nebulizer being present. And that's what the learn base flow would end up being used for. And there's a help key that is there also that will give you some idea of what the various alarm parameters are. More often than not, though, we're not going to be using the CPAP mode. We're going to be using the spontaneous timed mode, where I'm alternating between an EPAP and an IPAP level, creating that delta, and augmenting this patient's spontaneous tidal volume. Okay? So every time it senses the patient triggering, every time it senses the patient inspiring, it's going to then alter to the IPAP level and boost the tidal volume. That faster flow that it will have at the higher pressure will increase and augment their spontaneous tidal volume. Once it senses that the patient is no longer actively taking a breath, it'll convert back to the EPAP level and stay there. And if you look at the graphic, it'll actually show if the patient's triggering or if it's a timed breath, because I'm going to set a backup rate that is there. And ideally, you don't want that little timed indicator to be there because the patient should be breathing faster than what the backup rate is. Okay, let's talk about settings. Well, no, let's not. I think I have that on another slide. But with the spontaneous timed, we're setting our two pressures, our IPAP and our EPAP. And again, you need to have that EPAP level at a very minimum of 4, if not higher than that, because you won't have sufficient enough flow to flush out the circuitry. We do have a backup rate, although again, this is not designed to support ventilation. We have a timed inspiration as far as how long the inspiratory phase should end up being. Kind of gives you an IE ratio. There is something called rise time that for our purposes right now, we're not going to discuss setting it. We're going to leave that to Mary in the fall because she covers it when she talks about pressure-based breath. But basically, it's how quickly do I get to my target pressure. So for instance, I have an IPAP of 10. Does it get there right away, immediately pressurized to 10? Or is there a little bit of a delay to getting to that 10? Sometimes you don't want to be really aggressive as far as how quickly that pressure is realized. And then FiO2, obviously, you can adjust between room air and 100% oxygen. When you're in the monitoring screen of the ST mode, it's going to go ahead and display the IPAP and EPAP level along with the patient's total rate. It'll also estimate that exhaled tidal volume, exhaled minute volume, and the pressure that is being utilized. And same kind of thing as far as the percent patient triggered breaths, which you want to see as a very high number. alarms. High pressure alarms should be set above the IPAP level. Did we say 10, Nance?
For the high pressure?
Yeah.
No, I thought we were going 3 to 5 above.
3 to 5, okay. Thank you. So whatever your IPAP level is, you're going to set that 3 to 5 above that. And the low pressure alarm should be set 3 to 5 below that level. Big mistake people make is they set the low pressure alarm below the EPAP level. That's not the intent. You want to make sure that it's able to reach that target pressure, not exceed it, but you want it to at least be able to reach it. So 3 to 5 above, 3 to 5 below. The low pressure setting also has the option of being delayed. So we may not want it to activate on each and every occurrence. We're going to say that we're going to allow a little bit of a delay. We went with 20 seconds?
Yeah.
Okay. Alarms have a sequence of beeps for whatever purpose. If it does have if it does sense an apneic episode, we're going to set that at 20 seconds. It'll alarm for that also, but doesn't sense any spontaneous triggers on the part of the patient. And there's also a patient disconnect alarm if it senses there's a massive leak that it can't compensate for because the mask has fallen off or it's become disconnected in some fashion. There's an exhale port alarm that basically senses the fact that there's a blockage someplace. If the patient rolls over onto the exhalation port. It is also an O2 flow alarm that will alarm if there's loss of oxygen supply. And then there's what they call a P regulation, a pressure regulation alarm that talks about there's a difference in pressure from the proximal and the set value. And it usually will occur along with the patient disconnect alarm because there's a massive leak. And proximal disconnect would be if it senses there's not something attached there. So when you turn it on, this is there's an options that you can go to on the screen itself. That it's kind of a biomed screen. You can adjust the brightness and the contrast. You can invert. So on midnight shift, you have a dark screen with light lettering as opposed to a light screen with dark lettering. Whichever you wish. There's a spot up on the upper left for error messages, so you can go back and look at those error messages that are present. Test alarms, something you should do each shift just to make sure that the alarms are functioning. And the other stuff really is just kind of biomed stuff. Adjusting the display we talked about. One thing that's not there is built in is a humidification system. And patients who are on long term, you'll want to have a humidifier because it's dry gas. And it's one of the problems we'll talk about interfaces this afternoon. Their eyes and their nose can get very dry. And that's why we want to have some kind of a humidifier. The humidifiers are just simply pass-over humidifiers. They're not very sophisticated. They're not heated humidified in most cases. They're just cold. Although that one on the left does show a heater there. Tubing is very specific, and you can't just use generic tubing. I can't be real cheapo and just use some aerosol hose like I would use with a nebulizer. I need to use the one that the manufacturer puts out because it's a specific length, and the ventilator assumes that you're using that tubing. If you use different ones, you're going to run into problems. That whisper swivel or the exhalation port basically has a built-in leak that is there, and that's why it's attached to the tubing permanently. If we didn't have a leak, patient would build up CO2 and run into problems. Cleaning, maintenance, again, just wiping it down with an alcohol or disinfectant of some kind. Circuits are single patient use, so we just throw them away. Interfaces are typically single patient use, so we just throw them away. And that inlet filter on the back, again, is just a dust filter. Just clean it if it becomes dirty. I'm thinking, yeah. Doesn't even look like it's in water. It's just floating in the air. Okay, let's do this.